I think the developments of metastatic kidney cancer, RCC, are really impressive. I think what we have seen since 2005 is that after an era of sort of old-fashioned immunotherapy with cytokines, interferon alpha and IL-2, the insight that we got from molecular profiling of tumors and from hereditary kidney cancer as well as sporadic cancer led to the discovery that VHL is extremely important in clear cell carcinoma. Clear cell carcinoma is the most important and most frequently occurring form of kidney cancer. We know that angiogenesis is extremely important, and knowing the targets that we are looking for in kidney cancer patients, we were able together to develop new targeted agents that are targeting this VEGFR, vascular endothelial growth factor receptor pathways that are sort of overactive in kidney cancer. We all know that it's a highly vascularized tumor, but because of the fact that we really got to know which targets, which proteins were relevant, we were able to develop new drugs. And so since 2005, there have been an explosion of large randomized trials testing novel compounds in metastatic kidney cancer. We got first-line VEGFR targeting agents like sorafenib, sunitinib, pazopanib, axitinib, but we also got another class of agents targeting metabolic pathways, which is also overactive in kidney cancer, and that's the mTOR pathway. So we also had a compound like Everolimus and temsirolimus targeting mTOR. So between 2005 and 2015, we had this tremendous number of novel agents that were all approved by FDA and by EMA. But more interestingly, recently we got another development, that is that for patients who already failed prior first-line treatment with VEGFR targeting agent, 3 trials were testing whether a combination of a VEGFR targeting agents plus everolimus was better than one of the 2 drugs alone. And it's a phase II study, it's a randomized study, but it was clearly showed that the combination of Lenvatinib and Everolimus was clearly superior. Really interesting data because we never before had a combination that was active and tolerable by the patients. We had a second trial that was a phase III randomized clinical trial testing a completely different class of agents. Nivolumab, a checkpoint inhibitor, so an IV monoclonal antibody that helps to break tolerance to tumor cells. And this large trial was also run in a fairly rapid way and resulted in a beautiful result, namely that giving patients who are elective for second-line treatment, treating them with nivolumab gives a much better outcome as compared to Everolimus. So the standard Everolimus was beaten, as to say, by nivolumab immunotherapy, a novel type of immunotherapy. There's a third approach which was also extremely effective, and that was an oral compound called cabozantinib. And cabozantinib is a very interesting molecule because it looks like an old-fashioned VEGFR targeting agent, but it's also able to target MET and AXL, and those 2 proteins are probably extremely important when patients become resistant to classical VEGFR targeting agents like sunitinib, pazopanib. So cabozantinib was tested against Everolimus in second line and was clearly shown to have better PFS and better OS. So also cabozantinib has now been approved by the FDA as well as by the EMA, and we are able to treat patients now with either nivolumab or cabozantinib, nivolumab IV, cabozantinib oral, or the combination of Lenvatinib plus Everolimus instead of the previous standard of care, namely Everolimus in second line. I think it's revolutionizing the way we are looking at patients with metastatic kidney cancer. It's revolutionizing the fact that we have many more drugs to choose from for patients with metastatic mainly clear cell carcinoma. It's even an issue now that we do not know as clinicians exactly how to choose between cabozantini, nivolumab or Lenvatinib plus Everolimus. So we don't have exactly the tools to select patients and say this may be the best treatment in second line for this individual patient and the other treatment may be, a better choice. So it's sort of a thing that we have to find out now. We have to work on that. But the fact that we have so many more drugs and that they have proven to be more superior to the previous standard of care in such a short period of time in oncology is really something that we're very happy and very content with.